Good morning, everybody. My name is Lee Breyer. I'm the Director of Transformation Services at VPQHC, the Vermont Program for Quality in Healthcare. And this morning, we're going to take a look at this technique that is widely used in lean circles, whether that be in manufacturing or healthcare or any other environment, really, that talks about A3 problem solving. And we're going to go through it and illustrate with an example. And hopefully by the end of this webinar, you'll have a good broad understanding of what an A3 looks like and how to construct one, and be ready to start off on your first ones. So with all that being said, why don't we make some inroads into starting. One other aspect to this, if anybody has questions midway through, please put them in the chat box for Zoom, and we'll be more than happy to address them as we go. But that being said, let's get started. So the agenda for today, we're going to talk a little bit about setting the stage, and by that I mean putting together the context of where A3s came from, what they're useful for, those kind of things. We're going to look at problems, and specifically problems that cause waste. We've been trying to align everything that we do recently with the IHI's latest initiative on the $1 trillion checkbook and the call to action for reducing waste. This is one of the tools that you can use to be able to do that. We're going to look at the structure of an A3 and how to put it together, and the methods that you use to be able to work within those different structural elements. And we're going to use an example A3 so that you can see exactly how that looks as we go through. And then we're going to summarize and wrap up at the end of it. So when I talk about setting the stage, we talk about healthcare organizations, and they're typically a collection of silos. And by that, I mean functional areas. It doesn't really matter the scale of them. The silos exist whether it's a physician practice or whether it's a multi-unit healthcare system. You got silos that constrain functional areas. And the patients, as they go through that, move through those silos on what we call care pathways. So we've got an environment where patients are moving through, and the functional silos are the areas where they receive care, but they have to connect between those silos. And largely what we've found is that those connections dictate the length of stay in any particular system. So all that being said, problems exist obviously at all levels, and they vary in complexity and impact. But the cumulative effect of all of this is between 30 and 50% waste on average. That sounds like an awful lot, but empirically, and there's actually been a lot of studies done on it now, these figures come up time and time again. I've actually seen it as high as 70 or 80%. I've also seen it as low as 5 or 10%. There's a huge range, which is one of the reasons why you really have to pay some attention to being able to evaluate how much waste is in that system. So problems exist almost everywhere. Solving problems and getting around them, the amount of time that people use doing that is vastly underestimated, usually. Again, you're looking at about 30% of time spent wasted, through much of it through problems. And by that 30%, I'm talking specifically about 30% of what the length of stay for a patient in a particular workflow would be in the healthcare system. So how many problems do you deal with every working day? Let's take 30 seconds to be able to look at responses for that in the chat box, please. We'll be happy to look at how many problems everybody deals with in every working day. Doesn't have to be accurate, just a gut feeling. About 35 from Holly. That's about normal. I'll give it a few more seconds. Okay, well, if you feel so inclined to put a figure up there for the number of problems that you solve daily, I'd be more than happy to look at it. But about 35, again, the range varies significantly, but 35 is about normal. And obviously, if you've got 35 problems and you spend a couple of minutes working on each one, that's 70 minutes gone right there of your workday. And that's just the problem itself. Never mind about switching on and switching off from solving the problem. About 3 hours worth, Ron? Thank you. Yeah, so 3 hours is pretty significant in an 8-hour workday. I don't know the exact percentage there, but it seems to correspond around the 30-35% range. So maybe even 40% at that point. I'll have to do the calculation. But either ways, we'd spend an awful lot of each day solving problems. So there's multiple ways to solve problems, obviously, and a lot depends on the complexity of it. So let's take a look at this thing that we call A3. It's really more of a thinking process. You know, there's a lot talked about in Toyota Production System and Lean circles about tools. At A3, technically, you can use it as a tool. I tend to think of it more as a thinking process that you're structuring around a specific tool. So you're looking at things like a medium to hard problem to solve, and I realize that definition is nefarious, but you know you'll know it when you've got it. It's not something that you can just solve and just do it. It's not something that you're going to be doing a small tested change with a PDSA cycle and then working on from there. This is a fairly meaty problem. It's probably got multiple factors, and it doesn't have any obvious solutions. Usually, these are things emanating from team workflows. So these are all indicators that an A3 might be the way to go forward with trying to solve this particular problem that you're looking at. I was trained by LEI faculty, the Lean Enterprise Institute. This is effectively their Bible on A3, Managing to Learn. It's written by John Shook, who was the first Toyota employee North American Toyota employee. Did a great job with this book. It explains it from two different angles, one being the person that's actually running the A3, and the other one being the manager that's coaching them to run that A3. So it has both of those simultaneously in the book. Well worth getting a hold of. So that's my plug for the LEI's Managing to Learn book. I've not found a better one. And as you can see, this one's kind of dog-eared. That's my personal copy. I use that all the time. So let's take a look at the methodology. Well, it's a problem-solving framework. It originated in Toyota Production System, as we talked about. And it uses 11-inch by 17-inch paper, which is classified as A3 in Europe and Japan, which is where the A3 name comes from. About 2004, it was adapted for the healthcare environment by Sid Jinnison and Durwood Sobek. And it's gradually, over time, become somewhat of a de facto system for problem solving. Some major healthcare systems have thousands of these things live at any one time. They work, but they need the right environment to be able to work within, and that's one thing that we'll talk about. So let's take a look at the structure of an A3. A quick overview. Well, it's, as you can see here, it's landscape format. So 17-inch along the bottom edge, 11-inch up on the vertical axis. And the easiest way to think about it is it's divided into two halves vertically. And the left-hand side, you're looking at evaluating the problem statement and the title for the A3, what the background context is and the current state conditions for the particular issue that you're dealing with, and a root cause analysis of problems that you find in that current state. On the right-hand side, you're looking at everything to do with the future state, which are the countermeasures to the specific root causes that you found. The future state illustration of what the process will look like after you've implemented the countermeasures. An implementation plan of how to actually get there. Potentially a cost and cost-benefit analysis. We'll talk about that. And some follow-up of checking that the changes that you've made have actually stuck. And just a small section on that. So as you can see, a fairly basic structure, but it works quite well, as you'll see. So how do you use this thing? Well, first of all, you're encountering the problem. So any of those 35 problems that Holly has, or the 3 hours worth of problems that Ron has, we're looking to encounter that problem, and then if you're really looking to solve it, you've got to observe it. You've got to observe that problem in the course of the work at the point where it happens. It's very easy, especially in a healthcare environment, I've found, to go back and rely on the EMR to be able to provide all of the data that people need. And people are conditioned to it now, because that's one of the functions of the EMR. What we've found generally, and certainly what I was taught and what Toyota teaches, is you've got to go look and see where that problem actually happens. And you've got to communicate with people that are affected by it to gather different perspectives on it. And obviously, during that, you're going to gather data. to help you really understand it. Once you've really understood that current state, then you can start to progress through an A3, and you go through the future state countermeasures, implementation plan, cost benefit analysis, and eventually measuring the effects of what's happening there. So that's really the basic throughput of an A3 for problem solving. These questions are useful as a reference when you go through the process of being able to define an A3. And I do come back to these time and time again. They're actually in that book, the Managing to Learn book. So what's the problem or issue? Who owns it? Sometimes that can be an interesting discussion in healthcare. What are the root causes and some possible countermeasures? Who are you going to decide how you decide which countermeasures that you're going to propose? How are you going to get agreement from everyone that is going to be affected by it? What's your implementation plan? How will you know if the countermeasures actually work? What follow-up issues do you anticipate? What problems could occur? And how will you capture and share the learning? These don't have to be 100% there for every A3, but they're a really useful guide to be able to refer back to, just to check to make sure that you're actually on track and keeping the A3 structured so that you can solve the issue. So let's take a look at the mechanics of it. Well, how do you actually make one of these things? Well, there's two different methods, obviously. You can do one manually or you can do it electronically. There are different ways to do it, but either way, a good A3 should tell a story. And this is a good rule of thumb for it. If it tells a story with a beginning, middle, and end, you've got a decent A3. So we use that a lot. I tend to use pencil and paper because that's the way I was trained. It's got a lot of advantages. It's fast. You don't have to worry about a computer or any different software program. You can focus on problem solving, not how to use a particular tool. And you can change things really fast and in almost any environment that you find it. Going around to different people on the workflow. You can take a piece of paper and a pencil and an eraser with you and make changes on the fly. It's one of the reasons it makes it fast. That being said, there are electronic ways of doing an A3. Most of the decent programs nowadays, Word, Excel, have got some drawing capabilities. Publisher in the Microsoft world has been used sometimes. The granddaddy of them all really is Visio. That's purpose designed for working with charts and flow charts and things of that nature. Visio is really fast when you get to know it and use it, but again, it is something that you need a computer for. So either way, is just to let you know that there are different ways to be able to get this done. So the first stage, we call it grasping the situation. How are you going to decide on that issue for your first A3? Well, you're going to go and observe the process itself and the workflow in real time at the workplace where it actually happens, and gather data so that you can truly understand the situation as it exists right now. And that data could be in multiple forms. It could be in location, and it could be just in terms of where people move from place to place. It could be time series data. It could be working on particular attributes. There could be all sorts of different pieces of data that are relevant to the problem that you have. So you just need to be wary of looking at what data that you need and being able to gather it so that you can really understand the current state. And once you understand it, one of the big differences between an A3 and the standard PDSA cycle is you're going to create a problem statement. And really that is usually iterative. It takes a few times to get it right. You're going to try and state it through the eyes of the patient. This is really the crux of patient-centered care. Everything is viewed through the eye of the patient in this particular philosophy. It'd be exact. Symptoms are often confused as problems, and that can cause difficulties when you're trying to define exactly what you're trying to solve. There shouldn't be more than 1 or 2 sentences, really. And as I said, be prepared to erase and start over. This thing will be iterative as you refine it and find out more. Here's one in a paper and pencil. I'm going to use this example as we go through. So we're going to try reducing wait times for a provider visit at this fictitious Fantastic Family Medicine. So we need to find out some background about this problem. This is where you clarify the issue or add historical document information. And you're really determining the weight of the problem. How important is it? How big is it? You're trying to get a concise understanding of that issue. And really, you're trying to fit it into the space that you've got available on that A3. And this becomes a theme as you're crafting an A3 all the way through. There's a reason why it was designed on one sheet of paper. It constrains thinking so that you can only put specific things down on a piece of paper and still have it legible and usable. That actually has got multiple effects, and quite a lot of them are good. So it's worthwhile getting that concise understanding so that you can fit it in this tiny space that you've got available on the A3. And this is what one looks like in this case. The patients have been expressing dissatisfaction at wait times to see a doctor. Fairly simple. Okay. So let's take a look at the current state. This is how the work actually happens now. And the idea is do it from observations. Again, the tendency is to fall back onto computer generated. You're probably going to have workflows drafted somewhere. In most places with an EMR, you're going to have workflows there. Try and look at the actual process and go through it, and try and represent it. Use stick figures, timelines, bar graphs, anything that illustrates that current condition to make your point. And as you go through and you actually generate that workflow, point down on there where you've got known problems and validate them. Go through the workflow, talk to the people that are actually responsible for making the workflow happen, and validate that those problems are real and they're in the right place. And so by doing all of that, you'll generate an accurate current state. Here's the current state for our example. Delays for a provider visit range from 0 to 44 minutes with an average of 10 minutes. Our 3 providers complain of difficulties in searching out missing paperwork needed for an effective diagnosis. So we're starting to get a lot more exact now. You've got some time data, 0 to 44 minutes with an average of 10. We know there's 3 providers. We know there's difficulties with searching missing paperwork. And this is just a high-level representation of the workflow that we're dealing with. And as you can see, we've got check-in, rooming, provider visit, and checkout. With the rooms not routinely available between check-in and rooming, that causes problems. Providers not available in the rooming process. You've got also stock out of supplies at the provider visit stage, causing delays. So we've, for the sake of this example, isolated these 3 separate problems. We talked about measurement. As I said, that's 0 to 44 minutes with 10 minutes as an average. Understanding the workflow really is what we're talking about. Don't measure everything, but measure enough so that you understand what the workflow looks like and really what the issues are. Again, time in the workflow is something that the patient will be very aware of. So always try and keep it in terms of the patient's viewpoint of this. Try to resist, again, default into the electronic systems. Always ask which method's going to be best. Quite often it's some kind of data that isn't necessarily measured by the EMR, and it is quite normal for you to have to go down there and observe and use manual methods to be able to generate the data that you need. So once you've looked at these problems, the next point is, okay, well, what's causing them? So we need to do some root cause analysis. It's quite normal at this point to have to consolidate ones that are related to each other. And again, that can be an iterative process. This is where the eraser comes in quite handily with a paper and pencil version. You're going to use an outlining format and ask why as many as 5 times to get to the root cause. Usually that is very effective. It doesn't have to be 5. I've seen it in 2 or 3. I've seen it even 6. Usually it's no more than 6. If you have greater than 3 main problems, though, it's probably too much for one A3. So the time at that point is to take a break, subdivide it, and produce others based on those individual problems. And you'll see why when we get to the end of this. An A3 has a balance associated with it, and it needs to be readable and legible and also have a balance of white space available. If you've got too much on it, it really impacts the usability and readability of it. So here's a root cause analysis of an example. So let's step through this for a second. Well, the providers aren't available when needed. Well, why? Sometimes they're attempting to find necessary documentation. Well, why is that? Well, the nurses don't deliver documents in a standard way because they've developed their own methods. And why is that? Well, because the prevailing culture rewards individual achievement over system improvement. So the second one, rooms are routinely not available. Why? Some patients wait in the room while the provider analyzes a computer system in his own office. Oh, why do they need to do that? Well, because that exam room computer isn't powerful enough to run it. And the third one, stocking out of supplies. Well, the restock procedure isn't defined. Why is that? Well, because the procedure's been passed down through tribal knowledge instead of formal training. So now you've got some root causes that you can work with that hopefully will be able to resolve these problems. So now we move up to the top right corner of the A3 and we start to talk about countermeasures. So we look at what are we going to do that will move us from the current state to the proposed future state. The countermeasures should be specific to root causes and they should be measurable. And what does that look like in terms of our A3? Well, we've got three sets of them. The first one, we're going to develop a standard method for delivery of documents. You remember that was one of the issues that we had. We're going to design a visually controlled set of drop-off points, train all the staff on the new procedure, and redesign those reward and recognition systems to reward group performance over individual. The room's routinely unavailable. We're going to upgrade the exam room computers and train providers on the access in the exam room. And the third one, the stock outs of supplies, we're going to redesign the restock process, put the most frequently used items on the supplier managed inventory system, and train all staff on the new procedure. So now we've got some very specific actions that we're going to take as countermeasures to these root causes. Of course, putting those countermeasures in place is going to generate a future state for this workflow. So it helps to be able to graphically represent or draw what's going to happen to this workflow once these countermeasures are put in place, and highlight in those features making it a better way, and validate that with team members as you go through. It's important from a vision standpoint of having that future state there so that people can understand what you're trying to achieve and how you're trying to actually make that happen. Real simple one in this case, we've got the supply managed inventory system between check-in and rooming, so making sure that the supplies are there for rooms. Where goal is below 10 minutes between rooming and the provider visit. The new computers in the exam room. So we've got a few things in there that that generate the new future state. So now we know what we want to do. How are we going to get it done? So you're going to put an implementation plan together, and it's a very simple one. Keep it at a high level. You're just looking at what, who, and when. And the assumption is that whoever owns this A3 is going to manage those projects at the project management level using their own tools. This is just a representation of the high level for these particular countermeasures. Here's what ours looks like. So we're going to design the restock system. Who's going to do it? The admin staff by 14th of July. Upgrade the exam room computer, the owners by 5th of July, and redesign the document drop-off process by the admin staff on the 21st of July. Occasionally, it's worthwhile having a cost or cost-benefit analysis in the A3 itself. I've seen both varieties. Sometimes it's very useful, other times it doesn't really matter. But the idea is, what's it going to cost to implement the plan? And can you put a dollar amount on the waste that you've identified and what you can get back? So the real crux of this is, does the cost justify the plan? Excuse me. Here's the one for us. Well, designing this restock system is going to take about $500 worth of staff time and about $100 worth of materials. Upgrading the exam room computer is going to cost about $1,000 for the new computer, and redesigning the document drop-off process is going to take about $800 of staff time and about $150 of materials. So it gives us the cost of the countermeasures to be $2,550. And what is that actually saving us? Well, the cost of the delays now we've calculated to be $20,000 in this case. The new costs of delays with these particular improvements in place is actually going to be $5,000. So that's a $15,000 improvement. The return on investment calculation, very simply, is 15,000 divided by 2550, which in our case gives us a return on investment of 5.9 to 1. This can be useful when you're trying to justify a particular course of action that may need some investment. And Quite often that is the case in, especially in bigger institutions. So I talked about follow-up. This is really talking about 3 to 6 months further down the line once you've implemented what you've decided for countermeasures. But you're trying to check to make sure that the actual process has changed permanently. And it doesn't need to be extensive, but it's just to follow up the information just to make sure that that's happened. And this is what it looks like for us. So we're looking at people to check it and dates, and that's very, very simple. We talk about owners in A3s. In the healthcare world, sometimes that isn't necessarily the way that people think. Um, in the Toyota system, an A3 has an owner, and they're responsible for not just generating it, but coordinating the implementation of the actual countermeasures. Um, they change often, though, A3s, so designate them with a revision number to keep track of changes, and don't be scared of actually regenerating them as you go. It helps to include the date that the A3 originated. And as you get more into this and start to use this as a de facto problem solving method, you'll find that there are multiple A3s going around at any one time. So it becomes worthwhile to have just this basic document control to be able to make sure that you're not treading on each other's toes. Here's what ours looks like. This tiny little block at the bottom. Owner is LB, revenue is A, and the date is 10th of April. So all that being said, let's take a look at what we've just generated. And the idea is to review it. So you hold it at arm's length. Remember I talked before about, is it neat or uncluttered and balanced? Is there a good mix of text and graphics? And have somebody else read it. Can they understand it? Do they recognize the purpose? And can they easily follow the flow? And importantly, obviously at this point, are there any obvious mistakes? So this is the full A3 that we've been working with. And as you can see, it's balanced. It flows correctly. You've got the beginning, middle, and end of a story as you go through it. There's enough white space to make it readable, but it's got enough detail on it to be able to guide this particular improvement initiative. And this is a fairly normal looking A3. You can use it as a communication tool. And in fact, all the way through generating the A3, you'd be using it as a communication tool. You can generate this synchronously with everybody on the workflow and to be able to generate it at one particular point in time. Or more likely, you can use it asynchronously, where somebody generates the first sections of it, takes it to other people on the workflow, and then sits down and works with them to be able to refine it as you go through. It works both ways. But the basic idea is you're co-creating this thing. And by doing that, you're getting buy-in by all of the people on that workflow to be able to implement those improvements. You can use it as a review process with your supervisor. And it can be used as posters. You can post them up in prominent places to show what's being improved. You'll know when this is starting to permeate your organization, though, because the language becomes normal. People start talking about countermeasures. They start talking about root causes. They start talking about implementation plans and how this all comes together. And that's usually a good indication of A3 thinking starting to permeate an organization. So in summary, it's deceptively simple, as you can see from the paper and pencil, but it's really not. There's a lot to think about. But if you get the problem definition right, everything else becomes an awful lot simpler. So if there's one thing you take away from this, definitely have that the problem definition's everything. You're looking at problem solving and staff development as an outcome of this, and it's proven. It has a demonstrable history of results, and there are thousands and thousands of examples of these things working very well in the healthcare environment. And I'm more than happy to discuss any of those with you. So that's my presentation for today, really short. If anybody has any questions, please put them up in the chat box and I'll be more than happy to address them. I'm going to give that maybe a minute or two just to, if we need to think about questions. Okay, well, in the absence of any questions right now, oh, there we go. We got one. For very complex problems such as timely discharge, can the A3 be used, or are there too many? I'm assuming you were going to say factors, but it didn't come through. Um, Timely discharge is actually one that has been studied an awful lot. I'm assuming that you're talking about in a hospital environment. Um, there's quite a lot of examples with timely discharge that can be used, um, and you can absolutely use an A3 for that. In fact, it's probably the best use of it. It's a complex problem. It's got multiple factors. The solution isn't obvious. So I would say that's a great one to use an A3 with. Um, I know that there's been a lot of work done on timely discharge, and there's a lot of very creative solutions that have been put in place. Um, there's a particular book from the Lean Enterprise Academy in the United Kingdom, Making Hospitals Work, it's called. And there's a great example in there of utilizing an A3 to be able to modify an entire hospital workflow, but specifically there's a lot about discharge at the end of that. So if that's something that you're interested in following up on, I'm more than happy to do that offline. But the short answer to my rather rambling answer there is that yes, there's definitely a lot of room to be able to use an A3 in timely discharge. So, repeat the reference. Yes, absolutely. In fact, I'll do better than that. Give me 1 second. I do nothing but personal service here. So this is the book, Making Hospitals Work. It's by the Lean Enterprise Academy in the UK. It's Mark Baker and Ian Taylor who wrote this thing. It's about 10 years old now, but it's actually a really great book. And I can try and show you the section, but yeah, it's difficult to actually explain it without going into it in depth. But that's the book, Making Hospitals Work, Lean Enterprise Academy. It's very worthwhile getting a hold of. It basically takes start to finish how to work with a hospital from the demand analysis standpoint. And it also uses the A3 method to be able to demonstrate at a macro level how to solve the issues that you've got there. So hopefully that'll help you. Again, one of the things that we're trying to do here is to be a resource, and we're more than happy to talk offline for no cost, obviously. So please feel free to give us a call, and we'll be happy to get into that. That being said, that's the end of the presentation. Thank you so much for being here today. We really appreciate it. And at that point, I will stop the presentation. And if anybody wants to get a hold of us, you can definitely do that with Lee at vpqhc.org. Thank you very much. Have a great day.